Hello, everyone, and welcome to The Deep Dive. Today, we're jumping into a topic that I think sits right at this fascinating intersection of hard science and, well, just subjective beauty. We're talking about midline myths and perception thresholds. Basically, what do patients and what do we as professionals actually notice when it comes to dental aesthetics? And our mission for this deep dive is, I'd say, pretty clear. We're going to tackle two really critical questions. First, how reliable are those facial features we always use, the eyes, the nose, as a guide for the dental midline? And then, maybe even more importantly, how much of a deviation does it take for someone to actually notice? We're talking about the average person versus a trained dentist. We're going to dig into the data that draws that line between what's acceptable and what's, well, just plain unattractive.
That's exactly it. I mean, modern cosmetic dentistry, it's all built on this foundation of objective parameters,
Wow.
right? We talk about symmetry, proportions, the midline. We need those measurements for planning.
Right. They're our starting point.
But here's the catch. If those objective rules don't actually line up with how real people perceive beauty, then we've got a problem, a big disconnect. The research we're diving into today, it sort of gives us that scientific calibration we need. It helps us balance our own clinical chase for perfection against what a patient will actually tolerate or even notice.
And this is where it gets really interesting.
Oh, absolutely. Because the data, you'll see, it suggests that a lot of our long-held beliefs about precision, they might actually be a little misplaced. We're going to show you exactly which deviations you really need to worry about.
Okay, let's unpack this then. Before we start worrying about, a 1 millimeter deviation, we need a solid starting point, the facial midline. For decades, clinicians have been trained to use certain landmarks. So what are those common reference points we traditionally rely on to find the center?
Well, the most conventional one, the one everyone learns, is the pupillary midline. It's usually abbreviated as PP.
Right, between the pupils of the eyes.
Exactly. It's basically a vertical line that runs right through the midpoint of the distance between the centers of the two eyes. And it's an intuitive place to start, I think, because the eyes are just so dominant on the face.
So the assumption is the whole face should just be symmetric around a line drawn right between them.
That's the one. And beyond the eyes, the sources also really emphasize looking at the external soft tissues. These are often thought of as the closest reference points to the true facial midline.
Okay, so what are we talking about there?
We're talking about the philtrum. That's the vertical groove you have between the base of your nose and your upper lip.
Right.
And also the midpoint of the width between the corners of your mouth. In practice, these landmarks are, they're absolutely essential for seeing the smile in context of the whole face. They give you a dynamic benchmark, not just a static one.
That makes perfect sense for visual planning. But of course, academia didn't just accept these traditional measures. The literature I've seen mentions a time when researchers introduced this new idea, a line they called TSEF.
Ah, yes, the true facial midline.
Right, and this was what derived from skeletal structures or deeper tissues, and the debate just kicked off immediately. Is the real center the good old PP line for the pupils, or is it this new, maybe more accurate TF line?
Yes, and the introduction of TF, it really forced a critical look at how reliable PP actually was. For so long, the PP line was treated as, well, almost sacred. If the teeth didn't line up with it, we just assumed the teeth were wrong.
Of course.
But if TF and PP were often different, then just relying on the pupils was, inherently flawed. The question then became, how strong is that correlation, really, between the pupils and where the front teeth actually meet?
So let's get to the hard data. Did the research actually confirm that suspicion, that the traditional PP line might be, well, a bit of a myth for predicting the dental midline?
It absolutely did. There was one really critical study by Eskelsen and his colleagues back in 2009. They took 102 dental students and used standardized photos to compare the relationship between that bipupillary midline, the PP, and the maxillary central incisor midline.
And the findings?
They were pretty conclusive, and honestly, a bit of a challenge to how we traditionally plan things. They found no statistically significant correlation between the bipupillary midline and where the central incisors met.
Wow.
And that was true for both men and women, no difference.
Wait, hold on. That's a finding that really stops us in our tracks. No statistically significant correlation.
None.
So that means if we just rely on a patient's eyes to decide where their two front teeth should meet, we're basically guessing. We're introducing errors based on just, normal human variation.
It's a hugely important finding, and it forces a real shift in our clinical perspective. The research just highlights the big limitation of using these external landmarks for internal dental symmetry.
They're still useful for something, right?
Oh, for sure. The interpupillary distance is great for general reference for orienting the photo and the face in the planning stage. But it's a poor predictor of the precise dental midline. You can't just draw a line down from the eyes and say, that's where the teeth have to meet.
So the final call has to be based on the individual, on the lips, the soft tissue when they're talking and smiling.
Exactly. Which immediately brings up the next big question. Universality. If that relationship is so weak in one population, does that hold up everywhere? Are the aesthetic norms we're aiming for actually global, or do we have to constantly adjust for a patient's ethnic background or gender? Are we chasing a moving target?
That is a perfect transition because that's a question I think every clinician has wrestled with. Do we actually need different aesthetic playbooks for different groups of people? You hear all the time about subtle differences in facial structure, which makes you think the goals must be totally population specific.
Precisely. And to look into that, we can turn to this just massive piece of research. It was a multi-center interracial study done by Owens and colleagues in 2002. It was incredibly ambitious. They compared facial appearance across 6 distinct racial groups.
Groups, who are they?
They looked at African American, Caucasian, Chinese, Hispanic, Japanese, and Korean populations.
That is incredibly comprehensive. So how big was their sample, and what exactly were they measuring to make sure it was all reliable?
They were really meticulous. They evaluated 253 people in total, 144 men and 109 women. And they used a very standardized protocol to keep everything consistent. They measured 13 specific extraoral parameters.
Okay.
7 of those were for the frontal view, things like lip length, nose width, and 6 were for the profile view. They were really focused on the macro features, the big architectural relationships of the face.
And what did all of this extensive cross-cultural data show? Were the differences between these diverse groups as big as you might think?
The results were genuinely surprising. I mean, truly, there were 2 major counterintuitive findings that really change how we think about universal beauty standards.
Okay, we'll see.
So, surprising result number 1 was about gender. Across the entire study, they found absolutely no statistically significant differences between men and women for any of the 13 parameters they studied, frontal or profile.
Wow, that's quite a finding. So at the macrofacial level, a lot of the aesthetic benchmarks we aim for don't need to be radically different based on gender.
Exactly. But the second surprising result, the one about race, was maybe even more striking. They found that for 5 of the 7 frontal parameters and 1 of the 6 profile parameters, there were again no statistically significant differences between the 6 different racial groups.
So you're saying despite all the obvious and beautiful diversity in how these groups look, the underlying mathematical relationships of the major facial structures, the geometry, was statistically the same.
Precisely. The study's conclusion was that most of these frontal facial parameters could probably be considered universal aesthetic norms, norms that apply broadly to both male and female patients from all sorts of different ethnic backgrounds. It suggests that our human perception of facial harmony on a broad level might rely on these shared geometric rules.
This presents us with a really interesting paradox then. On the one hand, the big macro features of the face show this amazing consistency, these universal norms, like the Owen study proved. But on the other hand, the micro detail, like the dental midline's relationship to the eyes, is totally unreliable, like the Eskelsen study showed. We have this solid foundation for the face, but the dental specifics are just highly individual.
That is the critical synthesis point. That's it right there. We can rely on certain big overarching norms when we're evaluating facial symmetry, but we have to be so careful when we try to translate a broad landmark, like the line between the pupils, into a precise microplacement, like the dental midline.
Okay, let's just circle back to that midline correlation for one more second. The sources mention all this conflicting data. Some studies show a really low match rate, like 10–20%, but others show a much higher one, up to 70%. That's really confusing for a clinician who's just looking for guidance.
And that variability is a huge part of the problem. That low match rate, the 10–20%, that strongly suggests most people's dental midlines do not line up with their pupils.
So the higher numbers might be outliers or related to specific populations.
It could be. The sources suggest it might be linked to demographic differences in the specific samples they used. The fact that you have these wildly different results just proves that a blanket acceptance of one single universal extra reference point is just...
well, it's too risky.
So the clinical takeaway is what? Even though the numbers suggest a low chance of alignment, clinicians still use these lines as a starting point, as a guide.
Exactly. They are guides, not gospel.
Yeah.
They are a valuable visual aid, a starting reference, a tool, not a mandatory target.
Right.
And this brings us right to the next, and I think the most crucial question. If the dental midline often doesn't match the facial center, how much of a deviation is actually visible to the human eye? Because if a 3 mm shift is invisible to the patient, forcing a correction might be a complete waste of time and money. This is the real core of it, isn't it?
Right.
The gap between our professional objectivity and the patient's actual perception. So we know the midline doesn't always line up. Now we need to define that perception threshold. And for that, we're going to dive into that landmark 1999 study by Kokich and his team. This is the one that systematically compared 3 distinct groups. The specialists, so orthodontists, then general dentists, and finally, lay people, your average patient.
The Kokich methodology was, for its time, just revolutionary because it isolated these specific aesthetic problems one by one. They took a photo of a really nice, ideal smile, and then they digitally altered it.
How so?
They introduced 8 common aesthetic issues, and they adjusted them in these controlled, measurable amounts, from 0.5 millimeter up to 4 millimeters in some cases. The whole goal was to find the exact point, the threshold, where each group started rating the smile as significantly less attractive than the ideal one.
So they pinpointed the exact millimeter where a flaw becomes noticeable.
That's it.
Okay, let's jump straight to the big one. Midline deviation. How far can that maxillary dental midline shift before it becomes noticeable and, unattractive?
This is the finding that really redefined aesthetic practice. Midline deviation, and this was a huge surprise, turned out to be the most highly tolerated discrepancy out of all 8 that they tested. It is incredibly forgiving.
Okay, so what are the numbers?
The data is just astonishing. The orthodontists, and remember, they're the most critical group, they required a massive 4 millimeter shift of the maxillary dental midline before they rated the smile as significantly less aesthetic.
4 millimeters. That's basically half the width of a central incisor. To a trained eye looking at a treatment plan, that would be a glaring, unacceptable error.
It would be. But here's the real bombshell. The general dentists and, most importantly, the lay people, the actual patients, they were unable to detect a significant difference in aesthetics, even at the study's maximum deviation of 4 millimeters.
So you're saying that a 4 millimeter midline shift is effectively invisible to the patient?
According to the study, yes.
That is just. It changes everything. Achieving a perfect zero deviation midline is something so many of us spend hours agonizing over. But if the patient can't see a 3 or 4 millimeter shift, then our pursuit of that precision is, an exercise in professional vanity, not necessarily patient benefit.
The study's conclusion here is clinical gold. It says a maxillary dental midline deviation of up to 4 millimeters is highly acceptable to the lay population and to GPs. And this is where we have to be smart about it. If a patient has a minor 2 millimeter midline shift and fixing it involves complex, expensive, or maybe unstable tooth movement, we have to ask if it's necessary, especially if there are no other issues. Our resources should reflect what the patient actually perceives.
Okay, so if the midline is the most tolerated flaw, what's the least tolerated? What's the thing that stands out immediately, even to a layperson?
That distinction, without a doubt, belongs to things related to the horizontal plane. The study found that incisal plane asymmetry, so a slant or a cant of the biting edge of the front teeth, and also incisor angulation, so a tilt or rotation, are the least tolerated and most easily detected problems.
And why is that? Why are we so sensitive to that?
It's all about our visual processing. Our brains are just acutely sensitive to the horizon line. That's the stable reference point in our world. And anything that breaks that horizontal parallel, a slant, a cant, it's immediately flagged by our visual system as being fundamentally wrong, much more so than a vertical shift that's still parallel to the face's vertical axis.
Okay, let's look at the numbers for that incisal plane slant.
For this one, the detection threshold just plummeted. Incisal plane asymmetry was the most easily detected issue for both orthodontists and GPs. Their perception was incredibly fine. They only needed 1 millimeter of cant.
1 millimeter.
Just one. Once that incisal plane tilted by 1 millimeter, the professionals rated the smile as significantly less aesthetic.
1 millimeter. That's 4 times more critical than their tolerance for the midline. That should fundamentally change how we prioritize things in treatment planning.
What about the layperson? The laypeople were more tolerant, but still showed a really high sensitivity. They required a 3 millimeter slant to rate it as noticeably unattractive. But compare that to their almost non-existent sensitivity to midline shifts. A 3 mm threshold for slants is extremely low. It proves they are very tuned into the horizontal elements.
So this is a critical distinction.
It is. The research is very clear on this. Patients are far more tolerant of a vertical shift, like a midline deviation, than they are of a horizontal tilt, like an incisal plane cant. So your clinical strategy has to be to prioritize horizontal symmetry, level the incisal plane, make sure the teeth aren't rotated, and worry less about getting that absolute midline alignment perfect. If you fix the slant, the eye forgives the midline shift.
And what about the angulation, the rotation of the individual central incisors?
For incisor angulation, or crown tilt, all three groups were surprisingly sensitive. Everyone, including the laypeople, detected a 2 mm discrepancy in incisor angulation as being significantly less attractive. The pros were a bit better at spotting it, but the key is that laypeople are sensitive to tooth rotation at a pretty low threshold.
So the message for clinical practice is clear. If you have a choice between fixing a 3 mm midline shift and a 1.5 mm incisal slant, you have to prioritize the slant. The first one is probably invisible to the patient. The second one is a guaranteed aesthetic failure in the eyes of any professional, and probably the patient too. This is where we can really apply this framework to all the other common aesthetic problems. We've established horizontal is king, midline is forgiving. Let's go through some other issues, like crown dimensions and gum issues, and see what their specific millimeter thresholds are.
Right, you have to know these numbers when you're designing restorations. Let's start with crown length, which often comes up with wear or eruption problems. For crown length, the hierarchy was the same. Lay people were the least discerning. They needed a crown to be shortened by 2 mm before they found it unattractive.
2 mm. Okay, what about dentists?
General dentists detected it at 1.5 mm, and the orthodontists, as usual, were the most perceptive, judging it unattractive at just 1.0 mm.
That means if I take a burr to a patient's tooth and shorten it by 1.5 mm, my GP colleague down the hall might notice, but the patient probably won't unless I go past 2 mm. That's the difference between achieving excellence for our peers versus satisfaction for our patient.
That's it exactly. Now let's think about crown width, specifically narrowing a lateral incisor. This ties directly into that whole idea of the golden proportion. Okay, so both orthodontists and general dentists agreed that a 3 mm narrowing of the lateral incisor was significantly unattractive. But lay people, interestingly, needed it to be even narrower, 4 mm, before they noticed the problem.
That 4 mm tolerance for the layperson is huge. We often chase that ideal ratio, the lateral being 2/3 the width of the central. But the study suggests if we end up with symmetrically narrow lateral, say 3 mm narrower than ideal, the patient just won't notice. It gives a really clear margin of safety.
It absolutely does. It suggests that if lateral incisors are symmetrically undersized, maybe we have a big window of tolerance before the patient feels they need expensive veneers or crowns. Again, it seems like symmetry really softens the blow of dimensional errors for the average person.
Okay, let's shift to gingival discrepancies. The gums. These can be really emotionally charged issues for patients, whether it's the black triangles or a gummy smile.
For the open gingival embrasure, the black triangles, the orthodontists detected this at a 2 mm deviation. The GPs and lay people needed a slightly larger space, 3 mm, before it bothered them. And this is so relevant for our post-ortho or periodontal patients. If you've managed a small black triangle, say 1 or 2 mm, the average patient is highly unlikely to be bothered by it. This data really helps us counsel patients on whether these minor spaces actually require complex interventions. If it's under 3 mm, the risk-benefit might not be there for the patient.
Okay, now for the big one. The gummy smile. The gingiva to lip distance. This can lead to serious treatment planning, even orthognathic surgery. How strict were the groups here?
On this one, the orthodontists were probably the most hypercritical group in the entire study. They rated a mere 2 mm display of gum as being excessive and unattractive. And they confirmed that 0 mm of display was the most attractive look. It just confirms that really strict professional standard.
But what about the patients?
That's where the disconnect is. The general dentist and the lay people showed much higher tolerance. They only classified the smile as unattractive when the visible gingiva reached a full 4 mm.
That is a fundamental 2 mm philosophical difference. The orthodontist is trained to see 2 mm of gum and think, this needs fixing. The patient, on the other hand, often won't even register a problem until it's twice as severe.
The clinical implication is enormous, especially when you're talking about surgery. If we propose a maxillary impaction to a patient who only has 3 mm of gingival display, we have to recognize that we are probably fulfilling our aesthetic goal, not their perceived need. That gap requires some very careful communication about what they'll actually get out of an invasive procedure.
Finally, what about the gum line itself? Gingival margin level. If the gum line is perfectly symmetrical but say a millimeter too low on both central incisors, is that noticeable?
Here is the other fascinating exception to the rule of professional sharpness. For this one, all three groups, orthodontists, GPs, and laypeople, were unable to discriminate between different levels of symmetrically altered gingival margins.
So symmetry is the great equalizer.
It's the ultimate forgiveness factor. If the gum line of the two central incisors is off from the ideal level, but they are perfectly symmetrical with each other, that deviation just loses its aesthetic impact. The focus should be on getting them symmetrical, even if the absolute level is slightly compromised.
So to pull all these numbers together, the data is just crystal clear. Lay people are the most forgiving, orthodontists are the most perceptive. But the big clinical message is the shocking lack of detection for vertical and symmetrical issues like midline shifts up to 4 millimeters. The high sensitivity is all reserved for those horizontal problems, slants and rotations.
Now that we know how much deviation gets noticed, we also need to know what people prioritize. Because noticing a tiny flaw is one thing. Caring about it enough to want it fixed is another. The Koch study actually had participants rank 10 facial and dental features from most noticeable to least noticeable.
Okay, so what are the professionals looking at first when they evaluate a face?
For the dental professionals, their training really drives their focus. They overwhelmingly prioritize tooth position as the most easily perceived feature, and general dentists also rated tooth color very highly. It's what they're conditioned to see.
Right, they see the smile components. And what about the layperson, the patient? What are they focused on when they look in the mirror?
Their focus is much broader. It's external and macro. Lay people ranked hairstyle as the most noticeable item on the list. Hairstyle. The second most important feature for them was mouth expression and lip shape, so the soft tissue frame around the teeth. The actual dental features, like position and alignment, were ranked significantly lower on their list of things they notice.
That's incredible.
It is. It's also worth noting everyone agreed on what was at the bottom of the list. Eyebrow expression was ranked as the least noticeable feature by all three groups.
So what does this mean for us in daily practice? It means the patient walks in having already thought about how their hair frames their face, and they're highly tolerant of a minor midline shift. Meanwhile, we, the clinicians, are zeroed in on that 1 millimeter incisal cant. We're literally looking at two different pictures.
And that creates a huge professional responsibility. Since these minor, highly tolerated issues like midline shifts are basically invisible to the average patient, we have to seriously question whether it's right to push for a complex or difficult correction. We shouldn't be chasing a perfect result that only another professional can appreciate, especially at the patient's expense. The study's advice is that our role as clinicians is to inform the patient of all the objectively measurable deviations we see. And then we have to let the patient decide what the overall aesthetic significance of that is to them. We're the diagnosticians, but they have to be the ultimate judge of their own aesthetic need.
That ensures our goals actually align with their reality.
Exactly.
Before we wrap up, let's just touch on those two surprising side findings. First, experience. You'd assume more clinical experience makes your eye sharper. Did the data support that?
It did not. The researchers looked at years of practice for both GPs, some up to 39 years, and orthodontists up to 27 years. The finding was that the number of years of professional practice had no effect on their aesthetic perception.
So it's all about the initial training, not the years on the job.
It seems to be rooted in that intense formalized education, yes, not just the accumulation of hours.
And the second one, personality. Do perfectionist doctors, the ones with obsessive-compulsive traits, do they have a keener eye?
They looked at that too, and the conclusion was just as strong. Obsessive-compulsive personality traits were found to be unrelated to a person's ability to detect these minor aesthetic flaws. Aesthetic perception seems to be a separate, objective skill. It's independent of personal compulsions or decades of practice.
So we're left with this clear picture. Professionals have these strict train standards, and they're focused on tooth position. Patients are broad focus, highly tolerant of vertical shifts, and they really only demand correction when symmetry is broken on that critical horizontal plane. Today's deep dive has been a really comprehensive look at the limits of human perception in dental aesthetics. We've established that the dental midline isn't statistically correlated with our facial features, and that perception thresholds vary dramatically. The crucial clinical takeaway is that we really have to shift our treatment priorities. We have to place the correction of horizontal slants, the incisal plane cant, the angulation, far above the pursuit of perfect midline symmetry. The patient can tolerate a 4 mm midline deviation, but everyone is incredibly sensitive to even a 1 to 3 mm break in that horizon line. Our mission is to provide outstanding care, and that care is defined by meeting the patient's perceived needs efficiently and effectively. So here's the final thought for you to consider.
Given that we now know lay people are highly tolerant of a 4 mm midline deviation, but professionals are trained to spot 1 mm of incisal plane can't, how will you adjust your pre-treatment consultation process to ensure your aesthetic goals truly harmonize with the patient's own perceived needs? Yerhit, Sando Isori is a playfa.